Hello and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Mary Beth Wenger and I'll be your moderator today. Now, before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post-test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by phone. The toll-free number is 800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. And we'll also be taking questions by email, so please email us at any time throughout this hour at phlive.ny@gmail.com. Now, today's program is called Take Your Best Shot, Injection Safety. Our guests are Dr. Gus Burkhead, Deputy Commissioner, Office of Public Health, the New York State Health Department, Dr. Evelyn McKnight, co-founder of the Honor Reform Foundation, and Gina Puglisi, Vice President of the Safety Institute at Premier Healthcare Alliance. And we thank you all very much for being here today. Looking forward to a lively discussion. We should start out first talking to Dr. Burkhead, just to give us an overview of some of the learning objectives we're going to be accomplishing today.
Well, thanks, Mary Beth. Yes, the focus of today's webinar is on safe injection and including safe intravenous infusion techniques to prevent bloodborne diseases like hepatitis B, C, and HIV. The specific learning objectives are on the slide to highlight the problem of unsafe injections, which I think probably is underappreciated in the medical community, and the patient exposures that result. To discuss the impact on public health agencies that have to follow up when these instances occur, to look at some of the barriers to providers to providing safe injection practices, and we can talk about those. Identify means of empowering medical consumers, in other words, patients, to ask questions of their providers. And finally, to explore the One and Only campaign. That's a national campaign that's going on to help providers and patients attain safer injections.
We should probably start out on a positive footing by describing what a safe injection is. Dr. Burkhead, could you tell us?
Sure. Well, basically, a safe injection is one in which the patient experiences no harm and does not expose the provider to avoidable risk. And again, I want to stress that we're talking not just about injections here, but also intravenous infusions. Any time you're putting medication into a patient through the skin, the potential for contamination can occur.
This might seem like something that a provider would learn in Nursing School 101, Medical School 101. Where is this breakdown occurring?
Well, that's a very good question. It would seem to be obvious, I think, and healthcare providers, as you say, should know about this. But I think it's a combination of things. I would say first a lack of appreciation that it's very easy to do something unsafe with injections and that infections can occur with more ease than I think we appreciated. There may also be some cutting corners, and there may be some engineering of the environment, multi-dose vials and other technologies that come into play here. So the kinds of transmission, the slide that we saw previously, you can have direct transmission where the same syringe is used to administer medication from one patient to the next. That you think wouldn't happen, but it if you're not paying attention, can happen very easily, and it can result, as we've said, in infections like hepatitis B, hepatitis C, and HIV being transmitted.
And indirect transmission?
Indirect transmission is the situation where you may have an intravenous tubing or a IV bag or a multi-dose vial that gets contaminated from one patient. In other words, you've injected something into the patient and go back into the vial or into the tubing, and then use that same tubing on another patient, and so the fluid in the tubing or the multi-dose vial can become contaminated and then passed on to the next patient. So either direct or indirect, you have to really pay attention to your equipment when you're involved with injections to be sure that you're not going to be transmitting diseases.
We have a very interesting slide that really kind of lays out exactly how this can happen, if we can bring that slide up, about how this transmission occurs. And Dr. Burkhead, can you walk us through that?
Right. So the first step, obviously, in any injection or infusion is to use a syringe often to remove medication from a vial. And then the medication goes into the patient. In this case, the little X's, I think, in the patient indicate the presence of a bloodborne disease like hepatitis B, hepatitis C, or HIV. And in the process of injecting, you have to assume that the syringe will become contaminated, even if you don't pull back on the syringe, simply injecting. And even if you're injecting that into an IV tubing attached to the patient, you have to assume that the IV tubing also is contaminated with whatever is in the patient's blood. So you take that syringe away from the patient, it now has the little contaminated viral particles there indicated in the diagram. And even if you remove the needle and throw that away, the fluid remaining in that syringe can be contaminated. If you go back then into the vial of medication to get more medication, the vial itself can become contaminated. And if it's a multi-dose vial that will then be used in a subsequent patient, you can transmit the infection. So you see the little X's going from one patient into the vial, into the equipment, and then back and available to be injected, unfortunately, into another patient. And I think we don't appreciate, but very small amounts of hepatitis B or hepatitis C virus can cause infection, and we're learning that it's a problem, even if you're being careful, if you do these kinds of practices.
Mm-hmm. And that slide really lays it out well so people can see exactly how it happens.
I think it's very clear from the slide, and it's not just a direct injection through the skin. I want to stress again that even injection into an IV tubing or something of that sort has to be considered to be contaminated as well.
Well, it's not specifically considered an injection. New York State Health Department has also been concerned about diabetes care and safe diabetes care. Where are some problems arising?
Right. Well, with a lot of new technologies, I think, again, we don't appreciate that blood contact is possible. So the new Lancets or diabetes blood glucose monitoring devices that you see here in the diagram can do break the skin. They can be contaminated with blood. Even if you remove the sharp part, the lancet, if you go on to another patient, the plastic hub may be contaminated with blood. And we've actually seen several instances of disease transmission, mostly in long-term care settings where the same glucose monitoring device is used on several patients. And as I say, even removing the sharp blade that breaks the skin, there may be blood contamination that can be transmitted on. So basically the message is never share any kind of equipment that could be contaminated with blood from one patient to the next, and that includes the lancets, the pens, and any part of the device really shouldn't be reused. These unsafe practices, in our own experience here in New York, have been linked to a couple of events of transmission. And the other thing to mention is that the insulin vials themselves, which are used to treat patients, should never be shared among patients either. You should clearly label any vial that's going to be used ongoing with the patient's name and not share those as well.
So the big question is, why are these incidents happening in the first place?
Yeah, well, I think there are a couple reasons. One is a lack of awareness on the part of healthcare providers. I think that even very small amounts of blood can contaminate equipment, IV tubing, multi-dose vials, glucose test monitoring devices. Very small amounts of blood can transmit disease. And as we are doing a better job of testing now, we have tests available for hepatitis C, for example. I think we're uncovering many instances where infection is occurring. Hepatitis B and C have long incubation periods, weeks up to months, and you may not always make a connection with a medical procedure that occurred in the past. But as we're doing a better job detecting these infections and then following up on them, we're finding more and more instances. So it's a general lack of awareness, I think, on the part of providers. And then, as we've discussed, the medical environment now with lots of injection tubes, multi-dose vials. Healthcare providers really need to be very alert and trained about what the potential risks are. There may also be some instances where the economics, people think they're saving money by reusing IV bags or other things, multi-dose vials, which really are intended only for use in one patient. So that may be a factor. And then just lax procedures. If you let down your guard, these things can happen very easily. That's what we're learning.
Well, the One and Only campaign gets this question all the time. Is this really that big a problem in the United States?
Well, that's a good question. I think we're uncovering more. It's probably a very under-recognized problem. As we do better surveillance and testing for these diseases, we're finding more and more cases. And nationally across the country since 1999, over 125,000 patients have had to be notified of a potential exposure. These are cases where we identify that transmission has occurred, and we have a whole population of other patients who may have had the same kind of procedure, may have been exposed in the same way to hepatitis B, C, or HIV, and we've actually had to do mass notifications of patients to come in and get tested because some of these infections can also occur without symptoms or obvious symptoms that would lead to a diagnosis, but the infections themselves can be quite serious long term with liver failure, liver cancer, cirrhosis being outcomes if not detected. So we do notifications when we identify a situation where we think there's been potential exposure. How big a problem is, we probably don't know the full burden of this, but as we've done more testing for Hep C and public health surveillance, we're finding many more of these cases. I think it's surprised us how frequently this does occur. So it's definitely a significant cause, I think, of Hep C that's ongoing risk in the medical environment.
There have been many small outbreaks and some even larger notifications, as you've just mentioned, and we have a slide that shows a few of them. This is not an exhaustive list by any means. We're not picking on New York State, but we just want to highlight, since this is coming out of New York State, this broadcast, that we've seen quite a few fairly sizable and important outbreaks.
Right. I think from the slide you can tell that we've seen both outbreaks with hepatitis B and C and combined. We fortunately haven't seen anything with HIV, but that's always a potential risk. And this has occurred in all kinds of medical settings. You can see private medical offices. We've had several. Some of these have been pain clinics, pain management clinics, where frequent injections or intravenous narcotics, other medications are used. Multi-dose vials may be involved, IV tubing. Some of these do occur in endoscopy settings. And this is not only due to problems with the processing the endoscopes, but also the intravenous medications that are given for sedation or other things can also be contaminated. So it's not necessarily a problem with the endoscopy itself. Oncology clinics, so you can see multiple states involved here and multiple different kinds of settings. So I think the message is this can happen in any setting where you're injecting any medications into patients on a routine basis through IV tubing or directly. In the pain clinic, sometimes the injections are into the spinal cord or other areas. So it can happen in a variety of ways. I think really people need to appreciate, medical providers need to appreciate the potential risk here and be sure that they're following, meticulous infection control technique when they're using injections, and not reuse any part of the apparatus, not reuse multi-dose vials, et cetera.
All right. Well, because of those incidents, New York State did join in 2009 the Safe Injection Practices Coalition's One and Only campaign. Its slogan is "One needle, one syringe, only one time." The Centers for Disease Control and Prevention is a member. In fact, our next guest, Dr. Evelyn McKnight, is a co-founder of the coalition, and she's going to be telling us more about a patient's perspective. She had a life-changing experience with unsafe injections in her home state of Nebraska. Let's take a look at this short video.
Hello, my name is Evelyn McKnight. In October of 2000, I was diagnosed with breast cancer and underwent chemotherapy at my local oncology clinic in Fremont, Nebraska. In less than a year, I experienced a recurrence of the breast cancer. Through the very thorough workup for the second round of chemotherapy, we found that I had become infected with hepatitis C virus. My husband, a family physician, and I were confounded. I had no risk factors for hepatitis C, no drug abuse, no risky sexual behavior, no transfusions before 1992. In total, 99 patients contracted hepatitis C at the oncology clinic. I bet you're asking, how did this happen? The outbreak occurred because healthcare providers at the clinic did not follow safe injection practices.
And Dr. McKnight, we're glad to have you here to tell us in person what happened to you. You've been described as the face of a patient, the voice of a patient. Set the scene for us, if you will. You come from a small town in Nebraska. How did this all happen to you?
Well, in 2000, I was diagnosed with breast cancer. I consulted the oncologist in our small town of Fremont, Nebraska, 20,000 people, the only oncologist in town. Went through chemotherapy. Everything seemed to go well, but unfortunately, I had a recurrence in 2002. It was determined I should have a very strenuous procedure called a stem cell rescue. During that workup, I was diagnosed with hepatitis C. We just did not know how this happened. We were confounded. I never engaged in any risky behaviors other than accessing health care. So it was very unsettling to us, but we went ahead and had the stem cell rescue. When we returned to Fremont, my husband returned to active practice. and did share with his nurse that that I'd been diagnosed with hepatitis C. Coincidentally, she had just sat with her son, who had gone through oncology treatments for testicular cancer. And Jean, the nurse, said, "You know, doctor, I saw something that went on in that clinic that I wasn't comfortable with. I spoke to the doctor, but I don't know if anything changed." So they put their heads together, and within a month diagnosed 4 more patients with hepatitis C, all of whom had been oncology patients. So the state health department came in, did an investigation along with the CDC. They sent a notification letter to about 650 people. 480 people were diagnosed, and of those 480 people, 99 of us had contracted hepatitis C because the nurse reused syringes to access a large saline bag for port flushes.
99 cases of clinic-acquired hepatitis C.
That's right, making us the largest single source cause of hepatitis C through healthcare transmission.
That led to a long journey on your part. What were the results of this medical mistake for not only you, but others?
Well, that's very true. Because we saw that there was so much that came about through this outbreak. Our cohort of 99 was studied by University of Nebraska Medical Center researchers and found that there were 6 deaths due to hepatitis C, not from the cancer. So we went to the doctor to be cured of one life-threatening disease, cancer, but we came away with a second life-threatening disease, hepatitis C, and 6 folks died because of the hepatitis C, not because of the cancer. There were 33 that went through treatment, and very fortunately 28 of them did receive a sustained viral response. That means they cleared the virus. There was one sexual acquired case of hepatitis C, a long-term sexual partner contracted hepatitis C from her partner. And there were 89 lawsuits. $16 million was paid from the Nebraska Excess Liability Fund to the victims. And there is, unfortunately, still, although it is lessening in a bit, conflict and complicated grief. So many emotions, so much emotional stress from this.
I want to get back to that in a minute, but I do want to point out a Never event you see on your screen is the book that Evelyn wrote about this, which reads like a medical mystery thriller. It's a really wonderful book. You should get it if you're wanting to learn more about this. But you mentioned conflict and grief. There's still a stigma that exists today for those diagnosed with hepatitis C.
That's very true. Unfortunately, that's very true. Personally, I was so stigmatized by the diagnosis of hepatitis C that we didn't tell anyone that I had it. We didn't tell our children, our parents, our best friends, our siblings. And in fact, I asked my personal physician if he would keep that diagnosis out of my chart. I just didn't want anybody to know. Stigma, unfortunately, does not help anyone. It does not help the victim or the loved ones or the community in general. It decreases self-esteem, and in my case, in many cases, it discourages access to medical care. You know, when we're so embarrassed that we don't even want to tell our healthcare provider about the diagnosis, then we're more reluctant to access medical care. There's many other emotions as well. There's worry, what's going to happen to me, what's going to happen to my children, what's going to happen to our finances. There's confusion, there's unfortunately guilt even when there needs not be. It is just a very difficult time of complicated grief.
You took all those swirling emotions and went on to found Honor Reform Foundation. Can you explain to us what that is and why it's a driving movement?
I will. Tom and I, my husband and I, saw all of this just very difficult negative outcomes of our outbreak. And we resolved to do whatever we could to prevent those outbreaks from happening elsewhere in the United States. So with my settlement award, we started Hepatitis Outbreaks National Organization for Reform, or Honor Reform. And we educate about safe injection practices. We also advocate for legislative and regulatory options. And we have worked with the Safe Injection Practices Coalition to launch a national health education campaign. So our basic goal is to prevent these outbreaks from happening anywhere else in the United States.
Looking at the big picture, what pieces need to come together in order to ensure patient safety?
Well, we think it's a three-prong approach. We believe that it's important that there be a component for safety by design. That is, that the injection system, the needle syringe system, has engineering designs in it such that it will eliminate as much as possible the human factor, eliminate the possibility of human error. It's important also to have a culture of patient safety, so we educate providers to administer safe injections, as well as empower patients to be a partner with their provider, to ask the right questions, to encourage safe injection practices, to ask their provider, are you using one needle, one syringe, and only one time for me? And we also believe that it's important to incentivize providers to give safe injections, whether that be by legislative reform or incentives through insurance premiums, however that can be to incentivize safe injection practices.
Where does the Alliance for Injection Safety fit into this picture?
So the Alliance for Injection Safety is a group of like-minded organizations, professional and industry organizations, that have joined with us to take this message to Capitol Hill. We've asked for a congressional briefing. We are asking for programmatic funding to continue to fund the One and Only campaign. We're designing a bit of federal legislation that will be the undergirdings of safe injection practices. And we are collaborating with the FDA, CMS, CDC, and Health and Human Services to, in whatever way we can, put some teeth into safe injection practices.
The patient is always topmost in your mind, obviously. What has your organization done as far as a toolkit to help a patient going through this?
Well, when I was diagnosed, I had so many different questions and needed so much information about what are my healthcare options, what are my options for financing, how will my family be taken care of, what resources are there in the community to help me with this. So we Honor Reform partnered with the Creighton University School of Nursing to put together a collection of resources from the patient's perspective to give some information about these very important questions. It has now recently been released through the Southern Nevada Health District to the Las Vegas area. It's just a very handy and helpful tool for those folks who have recently been diagnosed with viral hepatitis.
I understand it was created in Nevada, but there are core pieces of that toolkit that could be used by anyone watching from anywhere in the United States. If you folks would like to send away for it, look at the URL on the bottom of the screen, but it can be tailored to other states, other locations.
That's very true. It can be tailored for a geographic specific region.
Okay, we would urge you to check that out. Well, you may be thinking to yourself, what exactly does this Safe Injection Practices One and Only campaign aim to do? Well, there are several missions, including educating providers, as we've talked about, empowering medical consumers, and wanting both of them to insist on nothing less than one needle, one syringe, only one time. Now, the Safe Injection Practices Coalition offers a free provider training video that explores the myths that sometimes lead to unsafe injections. Here's just such a scenario.
I'll just need a vial of lidocaine, a vial of Kenalog, a couple of needles, and one syringe. I already have the drape and skin prep.
One syringe? Aren't you giving 2 injections?
Yes, but after I inject the lidocaine, I'll just change the needle and draw up the Kenalog.
I'm sorry, but I'm going to have to stop you right there. First, we use multi-dose vials of lidocaine and Kenalog. Multi-dose vials must be drawn up in our medication prep area, and they can't enter the patient treatment area unless we're dedicating them to that patient and discarding them at the end of the procedure. And more importantly, reusing a syringe to access a medication vial is not safe.
Those myths and misconceptions were quite apparent in a recent study that was co-authored by our next guest, Gina Puglisi. She is Vice President of the Safety Institute for Premier Healthcare Alliance, and thanks for being with us today, Gina. You co-authored a study of U.S. providers indicating that most of them are doing the right thing, which is heartening, but you found an alarming number that may be misusing certain items and certain devices. Even in the present day, we've seen a number of stories about this in the news, and we see one right there. These incidents are still happening?
Yes, it's absolutely amazing that that in today's age we're still seeing this. What we tried to do was establish a baseline and to see exactly where the practice was at, both in the hospital and the non-hospital setting. So we conducted a survey and we partnered with about 10 organizations to make sure we got a representative sample of practitioners across the spectrum, physicians, nurses, technicians, anesthesia personnel, technologists from the laboratory, dialysis settings. So all the settings that we deliver health care, both in the hospital and the non-hospital area. We had about 8,000 respondents, so we had a really nice response rate. We did remove anyone who had not prepared or administered medication, so that we were only looking at people that actually practiced and gave intramuscular parenteral injections of some sort. So we ended up with about 4,500 in the final sample, and we analyzed what they did, and we found some very alarming practices.
Well, what did you find out about practices that the CDC guidelines do find acceptable?
Well, there's a number of practices that are considered acceptable provided you use aseptic technique. I mean, that's really the key. For example, are you using a syringe that was prepared by somebody else? I mean, if the syringe was prepared properly with aseptic technique, there's no problem. But you don't always know how the syringe is being accessed when you give the medication. So, that was about 71% of the people never do that, but 30% of the people do that. So there is a potential risk that if it's not used carefully. How often you enter a single dose vial more than once to obtain additional doses for the same patient was something else they asked. Most people don't, but about 30% still do re-enter the vial. Now, hopefully the vial wouldn't be used on anybody else, but there's always a chance when you re-enter a vial, particularly with large vials where there's more medication in the vial, that it would be left for another patient. And as Dr. Burke had said, the perception of cost and wanting to save your organization money. How often do you use a multi-dose vial for more than one patient was another question we asked, which is an acceptable technique as long as you're using asepsis. Interestingly, 34% never do this. So there's a lot of organizations that have really, set the bar very high and decided that they're not going to allow multi-dose vials to be used for more than one patient as a safety mechanism.
We've said that most of the clinicians that were surveyed are doing the right thing, and that's good. But do you think that those who weren't doing the right thing knew that they were putting patients at risk? Were they aware?
No, I don't think so. I think that when somebody comes to work in a healthcare setting, that they don't come to harm a patient, that they truly believe that what they're doing is proper technique. I mean, there's very few situations where people come and, recklessly do something with the intent to harm. So these are people, as Dr. Burke had said, that are really unaware of what they're doing. And we found that most of the clinicians were following safe practices, as you mentioned, but some of the inappropriate practices that we asked about, and we divided up the survey in a way that we didn't say this is inappropriate, do you do it? We mixed in all the questions together, safe and unsafe, just in order, just as you do them, and whether you do them sometimes, always, or never. So to really pull out, and it was anonymous, so we felt that we got very honest answers. And when we asked if they used a single dose vial for more than one patient, what was interesting is 6% of our population, which is about 300 people of this sample, are using single-dose vials, which do not have any preservative in them, which is very risky. Unfortunately, some of these single-dose vials, for example, 100 cc vials of propofol, which are commonly used in clinics and non-hospital settings, are used for more than one patient. They don't have preservative. They're very risky because they support the growth of bacteria, when in fact these 100 cc vials really are more appropriate for intensive care and long-term sedation of patients. So that was very alarming. One of the practices, which is using the same syringe on more than one patient and just changing the needle with the perception that the syringe doesn't get contaminated, only the needle does. 1% of our sample, which was nearly 50 people, are practicing this. Most of the comments in the survey were pretty humorous because people thought we were kidding when we asked that question. But there were some people that reported doing this. And what was also alarming, and what really supports the need for empowerment of our workers to speak up, is that some people said they don't do this, but they see others doing it. Which is very, very concerning. Also, as Evelyn pointed out, what was happening in the clinic where she was at, using a large bag of IV solution as a diluent for more than one patient, or using it as a supply. That was practiced by about 9%, almost 500 people are doing this. And the comments that are made in the survey were very revealing, saying things like, we only do this in the medication room, or we change the bag every 24 hours. That those were their controls for this unsafe practice.
Or I've seen someone do it. I don't do it myself, but I've seen others do it.
Exactly. And, but we don't have vials that are right size vials for the procedure, and there's all different size vials, and the perception is if you have a very large vial or very large bag, and if you use good technique, that you can use it over and over and over again for many patients, even though it's not intended to be used like that.
Well, your survey also uncovered more information as to why it's risky to enter a syringe with or enter a vial with a reused syringe, and how often clinicians may be doing this.
Well, technically, you can use a multi-dose vial for more than one patient. The risk is when you start reusing a syringe to go into the vial more than once. And if you re-enter the vial, as Dr. Burkhead pointed out in that scheme of how things get contaminated, you contaminate the vial after you use the syringe on a patient. Now, if you're throwing away the vial, everything's fine. But unfortunately, that doesn't always happen. And even if you intend to throw away the vial, sometimes it gets left on a cart that's used by multiple patients, and then you run the risk of somebody inadvertently using it. But we specifically asked people that admitted to reusing a syringe to enter a vial, what do you do with the vial when you're finished? And most of them, fortunately, about 85% of them said they never, ever reuse the vial. But 15% of them said, we leave it for use on another patient. And so we asked, and so that was about 51 people are doing this, which sets up an opportunity for an outbreak waiting to happen when this goes on.
You uncovered some reasons why healthcare providers may not be following safe practices. What did they tell you?
Well, you learn a particular technique in school of what is safe practice, and then you sort of add your own concepts of what would keep something aseptic, because of course germs are not visible to the naked eye, so you have this perception that what is clean and what's contaminated. So as we learned, if you don't see visible blood in the tubing, there's always been the perception that you can use a needle into an IV tubing because you're going into sterile fluid and there's no risk. And this was a very common practice in the anesthesia profession for many years before it was realized that microscopic drops of hepatitis virus in very small doses can line the tubing and not be visible to the naked eye and transmit hepatitis, for example. Also, the perception that if you don't withdraw on the plunger, you're only injecting medication and a constant push, as Dr. Burke had mentioned, that you're not really contaminating the syringe, which is also not true. And then I think that I also mentioned just the size of the vials is really been very confusing. And the perception in this healthcare environment with belt tightening that we're seeing more and more, there's a perception that you're saving your organization money if you can reuse things or cut costs. We did an analysis at Premier to look at the cost, for example, of propofol, the average cost per cc, because it comes in various size vials. And what we found is that the average cost of 1 cc of propofol is the same no matter what size vial you're using. So when you think you're saving money, you're really not.
That'd be very interesting for a lot of folks listening to know. That's great. Thank you, Gina. Well, Dr. Burkhead, I want to return to something that we've all talked about, consumer empowerment being one of the goals of the One and Only campaign. And getting patients and providers to have that conversation. But we do realize that there are some barriers to that. What exists that kind of puts a roadblock between two people having that conversation?
Well, you're right, Mary Beth, that we're in a new era in healthcare now where we urge patients to talk with their providers and their physicians, and many people do that. But it does, I think, still feel like it goes against the traditional doctor-patient relationship, and that may be a hard barrier for patients to overcome. They're relying on the physician. They don't want to make the physician angry, but yet these questions, I think, are helpful to be raised. We certainly have healthcare providers who don't want their patients asking them. That's probably a minority now, and people, I think, are having to get used to that feeling, but that could be a potential barrier. And patients may be intimidated. Obviously, they're in a relationship with a provider where they're depending on them for their health care, and again, don't want to make them angry. And then finally, I think, as in Dr. McKnight's case, you're there with the physician because you have an illness that's really what's occupying your mind, and this may be further down on the list. And I think we just want to make patients aware that in talking with providers, this is one of the things that could be mentioned, should be mentioned, just to be sure, as part of a dialogue with the provider on the whole range of care issues that they're experiencing.
That's a very big point. In one of our New York focus groups, a lady said, I have a laundry list of about 30 things I want to talk to my doctor about. Maybe I see him once or twice a year. This is going to be way down on the list. But consumer empowerment, as we mentioned, is one of the goals of the One and Only campaign. But as we've said, asking providers medical questions can be daunting. Here's a video produced by the New York One and Only campaign that could help. Most healthcare providers will be happy to answer your questions. But for those rare other instances, here's how you might handle the situation if your provider dismisses your concerns.
Okay, Tony, looks like, looking through your chart, it looks like I can give you something that can make you feel better right now.
I've heard that you can get an infection, like hepatitis, if a syringe is reused. Should I be worried about that?
When did you get your medical degree? No, you can't believe everything you read on the internet.
I'm asking you because you are the expert, and you're the best source that I have. It's not just me asking. It's respected organizations like the Centers for Disease Control and Prevention and the Safe Injection Practices Coalition that are encouraging their patients to ask this for their own health and peace of mind.
And we do want to point out that rather brusque doctor is in the minority. Most providers will be taking your questions, would be happy to do so, but that's just a way to help you if you encounter some problems. This is a reminder that we are taking your questions throughout the hour. You can call in at our number 800-452-0662, or you may send your written questions by fax. The fax number is 518-426-0696. And we're also now taking questions by email. You can reach us at phlive.ny@gmail.com. Well, Dr. Burkhead, I want to return to another topic here. Without question, unsafe injections do take a toll on public health agencies like your own because it regards investigation, patient notification, media notification. What things are you seeing as far as that goes?
Well, this has really put a burden on public health organizations. These do happen, and they take a lot of time and personnel from the health departments to try and track down the initial infection, what happened, and then who else might be exposed, how do we notify them. So this is really taken on, we actually have set up a new unit here at the State Health Department to try and deal with these because it has become so common, and it is a very large effort when we do get to it. We have the media as part of that team because we often use the media to alert people when we don't know exactly who may have been exposed. So it's a multidisciplinary approach that we have to take in doing these investigations, and it takes a lot of time.
You brought up Nevada, and that's a good example. It's hard to get firm numbers on what this might cost, but the Southern Nevada Health District had a notification of about 63,000 people in 2008, and their estimated total public health cost, including the investigation, the testing, medical counseling, was between $16 million and $21 million. So you can see the toll that it takes, and I think, Gina, you've said this is a cost that's borne by all of us. Gina, I want to touch again on the patient safety culture and the fact that we need to change the culture. What things do we need to work on as far as that goes?
Well, I think educating the patients, in simple language, and educating the healthcare providers as well. And as we just saw in the video, just to actually feel empowered to be able to speak up and encourage that. And once we do this, we can really help in so many areas that we're trying to really empower patients to really take an active part in their care.
Change perceptions of cost containment for one?
Change perceptions of cost, for example. I mean, a lot of people think, as I said, the vial size, that there was a real huge difference, or they're saving money in their organization by, reusing a very, very inexpensive syringe. But the empowerment, I think, is a really big piece, because it helps. It really helps move things along. We're trying the empowerment with hand washing, other things where we're trying to get the patients more actively involved to really help us, because practitioners don't really want to harm someone, and the patients can really help us as well.
And Dr. McKnight, we want to touch on some of the resources that the CDC has to help educate patients. And also providers. What items are there? And also the Safe Injection Practices Coalition. There are websites. There's a lot of good information.
There is, Mary Beth. There is a very nice website, oneandonlycampaign.org, that gives lots of good information, as well as a spot on the CDC's website for safe injection practices. There's brochures designed for patients. There's brochures designed for providers. There's posters. There's the training video that you alluded to earlier. There is an online opportunity for CME for providers. There are guidelines written by the CDC, as well as I think a very important part of the website is the section of frequently asked questions. And this is rather interactive. People can write in their questions and make their comments, and then often you might see that as a new fresh piece on the FAQ tab. There's also a Medscape video that speaks specifically to some of the myths surrounding what is a safe practice and debunks those myths. So there's lots of good information available.
And I'm glad you mentioned Medscape, because the Safe Injection Practices Coalition is going to be coming out with a CME, a new CME through Medscape, late June, perhaps sometimes later in the summer, but we're very much looking forward to that. So please go on the website and keep abreast of that. We'll be letting you know as soon as possible, because that's something that nearly any provider could possibly get credit for. Stepping back, I want to mention one other aspect that's kind of a disturbing trend, Gina, that we have talked about, and that is providers who may be drug abusers themselves and who may be accessing these syringes and then not disposing them because of a drug addiction. What have you seen?
Well, there have been a lot of reports, both public reports and private reports among clinicians reporting diverters, since a lot of these medications are unattended in the hospital, and if you have a drug problem, it's easy to get access to those syringes when no one else is looking, use them on yourself, replace them with sterile water or sterile saline, and infect the patient. And what hospitals are doing is developing policies, because many of these practitioners, some of them technicians, are not licensed in the state. And when an investigation starts, sometimes the practitioner leaves before they're able to test them, and then they never really find out the source of the hepatitis or bloodborne pathogen infection that happens. So hospitals are starting to develop policies that actually require the healthcare worker and the patient to be tested when there's any suspect diversion happening and a potential risk involved.
We've seen episodes of someone self-injecting with, say, fentanyl, and then replacing it with saline and putting the syringe back on the operating cart. People can't even imagine that could happen. But
right. And in Colorado, there was just a technologist who was accused and convicted of diverting in 2 different states. Went from one state doing diversion, went to another state and infected a significant number of people, and was, I think it was jailed for 30 years.
30 years.
Yeah,
Yes.
30 years imprisonment, has 2 small children, but diverted for a very long time at multiple hospitals before it was caught.
And this person had hepatitis C as well.
Yes, hepatitis C.
Well, we do have an emailed question, and Dr. Burkhead, I think I might address this one to you. The person writes in and says, I understand not using insulin pens, Lancet, and Lancet devices on more than one patient, but what about the actual glucose monitor?
Well, I think there are multiple kinds of these devices around, and you need to sort of look at each one, look at the package insert. FDA has some warnings on some of them. The basic principle is if blood is contaminating any part of the device, that part should either be meticulously decontaminated if that can be done, or not reused. And I think a good rule of thumb is not to reuse unless you're certain that you have a device that's been shown to be safe and able to either be decontaminated, or blood does not actually come into contact with the part that's being reused. So it's a little bit of a case-by-case basis because there are lots of these kinds of devices. But the basic principle, again, is if there's blood present, should not reuse it unless there's a certain protocol for how to decontaminate it.
Dr. McKnight, I want to touch on something that we have discussed at length. What if some of these outbreaks had never been detected? Yours might have gone undetected.
And
we come so close sometimes to missing them completely.
That's very true. And the outbreaks that we do know about may be just the tip of the iceberg, likely. I mean, how many times does a transmission of just one case happens? And because hepatitis C is so slowly developing, for most people it may be 20 years before they show significant signs of liver damage. And they may not realize that they have this disease for 20 years. So that adds another level of complexity and scariness to the situation.
We have a few more questions coming in. This one says, if you're drawing up batches of medication, for example, lidocaine from a multi-dose vial, can you use the same needle just for drawing up purposes? Each syringe would get a new needle applied before administering to the patient.
So I think the question is, you have a multi-dose vial and you're drawing up multiple syringes from it. So I'm not quite sure why you would be using the same needle. Perhaps they're saying you would leave the needle in the vial and reattach a different syringe to it. Obviously, if that hasn't been in touch with a patient, you're not creating a problem. But I would think, just trying to think back to my practice, you would probably be easier. The syringes may come with a needle on them anyway to use a new complete apparatus. But since the patient, there's no involvement with the patient in this scenario, it probably would be okay. But as a matter of sort of developing good practices that are automatic, I think it's probably better to use a new needle each time, to be sort of automatic about it and not have a question, rather than to say, oh, in this situation I can, in this situation I can't. If you have to think too much about it, the chances of making a mistake get injected at that point. Sorry.
Don't leave anything to chance at that point. We have another few questions. One is, do different states have different laws they need to follow regarding reuse of injections? And this person says, as a former chemo patient, I was overwhelmed when getting my treatments. I started out at a New Jersey doctor's office and noticed mistakes upon mistakes. It added a great deal of stress to my treatments. So do different states have different laws?
No, they're all under the same requirements. I mean, everyone follows the CDC guidelines, and the CDC guidelines very carefully point out what you can and can't do. And some of their recommendations are to have that margin of error, like never re-entering a vial for any reason with the same syringe, to as Dr. Burkhead said, to make sure that you have that margin of safety.
Yeah, I don't think these are issues where there's actually a state law that says, do not reuse a syringe. It's more the state law that says physicians and other healthcare license providers need to follow standard medical practices, which the CDC guidelines would constitute. So I don't think there's a difference really from state to state in what people should be doing, and generally laws are not to this level of detail. They're more referring to standards of practice.
Right, you can always check the CDC guidelines if you're at all questioning. And maybe, Dr. McKnight, you would like to take this one. A person asks, would it be helpful for patient empowerment to bring along a family member or a friend to ask the hard questions? And that's a good point, because sometimes as the patient, all the focus is on you, you're stressed out, tense, maybe you're not asking the questions you should.
That's very true. That's a good point, and I think that is certainly a lesson that I've taken from this personally. It is good to have an advocate there with you, watching over things, being your advocate. I have to admit that Tom, my husband, was my advocate. He was there with me, but back then. He was watching me, he was not watching the nurse. So I think there is this new level of understanding that we do want to be partners, and perhaps sometimes to be the best partner is to have a intimate partner with you to advocate for you.
We have a question for some clarification. In the presentation, it was mentioned insulin vials are not to be shared amongst patients. Later on in the program, you mentioned the CDC does not prohibit the use of multi-dose vials amongst multiple patients as long as safe injection practices are followed. So can you elaborate why insulin vials are to be single patient use versus any other injectable medications, for example, lidocaine?
Well, I think the answer is that insulin, I'm not sure it's really a special case, but patients on insulin get it on a regular schedule. It's not different from propofol potentially, which is used only one time during a procedure. When you've got a ward with patients on it, it makes sense, I think, to keep the insulin vials labeled with the patient's name and not share them as a good medical practice. With the propofol example, in theory, if good infection control practice is being practiced in the OR, you can use a multi-dose vial. But I think even there, again, the best practice would be not to do so if you can avoid it.
Right. Well, we have a question from West Virginia. What about the practice of reusing needles for insulin injection? What should be taught to the patient? Reuse of insulin pens is the question.
You know, the whole insulin issue was the subject of a special conference that the CDC had, because there's so many questions regarding, insulin and contamination. When you're talking about a patient using something on themselves in their home as their own unit, that's one thing. But then if you don't teach the patient about, infection risks, they may be sharing their insulin pen with their cousin or somebody else, a neighbor. The issue with insulin and also these glucose monitoring devices is that the ones that are sold for use, for example, in long-term care facilities, are sold for use on multiple patients. And of course, the blood, if it's not visible, is problematic. And there's also a greater risk of transmission with the glucose monitoring devices. You have to bring the finger up to the device to get it tested versus using the strip on the finger and then bringing the strip up to the machine. But either way, there's an opportunity for contaminating the machine and then contaminating the patient. One of the problems that happens in hospitals is that you have a glucose monitoring device for a patient or a particular insulin vial or an insulin pen or whatever, and somebody gets a stat requirement for a stat glucose or something, and there's this, I'll just borrow my neighbor's one, and that's where the problem comes in. There's also a special section on the CDC website for glucose monitoring with recommendations for disinfection of equipment and what guidelines you should follow, and directing you to the FDA for the kinds of chemicals that you should use and the proper techniques. So I urge anybody that's involved in writing practices or policies for insulin would refer to the CDC website and guide their policies according to that.
And we have one other question, which is a very good one, about efforts going forward looking at new technologies in safe injections. And Gina, Premier Healthcare Alliance recently, in collaboration with the Safe Injection Practices Coalition, held a seminar, a one-day conference called Safer Designs for Safer Injections. And any of you can jump in here. There's some talk about possibly engineering out human error. Is that possible? What are we working on to that end?
Well, I think that's what we'd love to do, is make it easy to do the right thing and difficult to do the wrong thing. And with any kind of technology, some of them are very simple, non-healthcare, unleaded and leaded gas have different nozzles, and that was kind of an easy fix. But, it's a little more complicated with syringes. There were some recommendations made at this multi-stakeholder meeting of suppliers and clinicians and patients, color coding perhaps of vials or syringes where there would be a change after it was used, auto-disabling of syringes and various things. But when you look at the places that injections are performed and parenteral medications are administered across the spectrum of healthcare, it's impossible to come up with a single technology or design change that's going to be effective in all particular settings. It's just impossible, but there's lots of improvements that can be made. And one of them that came up loud and clear was the labeling issue, because there's so many different terminology is used: single use, single dose, single patient, and they all have different meanings to different people. And so if there could be the standard terminology, perhaps, and also right sizing of the vials for different procedures. So rather than creating a vial, a huge vial that you only need a few cc's for most procedures, maybe right sizing those vials. So those were some of the things that came up in the discussions.
I think for most infusions, parenteral infusions of medication, chemotherapy, and other things, you know, there may be something out there that we haven't invented yet, but you're still going to be using potentially tubing, vials, where a potential for a problem can occur. So I think we still need to work on the engineering needs to be fixed as best as we can, but we also need to work on the education of the providers and really sticking to sort of a simple rule: no reuse of any of the components from one patient to the next.
And if that's the one thing you take away from today, we would be very happy. We do thank you very much for joining us today. We did have a quick question about how to get some of the videos that you've seen on this broadcast, and go to the websites that we're going to be mentioning at the end and you can find some of them. Please remember to fill out your evaluations online. Your feedback is very important to us and helpful to the development of our programs, and continuing education credits are available. An archive of this webcast will be on our website within 2 weeks. So please join us on June 16th for our next webcast, Vaccinology 101. Thank you to all our guests today. I'm Mary Beth Wenger, and we thank you for joining us on Public Health Live.